Hi, it's Michelle with the Medicine Couch. Welcome to my channel. In today's video, we're going to be talking about the specialty of obesity medicine. I think you'll really love the guest today. She is a PA who's been working in obesity medicine for quite a while and has come up with some products and some ideas of how you can actually incorporate obesity medicine into your practice. Obesity medicine is unique in that there are some amazing opportunities for PAs and NPs to step up and become authorities in this specialty. Stay tuned and hear what our special guest has to say.
Hey everyone, my name is Karli Burridge. I'm a PA and a fellow of the Obesity Medicine Association. I've been a PA since 2009, and I've been working in obesity medicine for about the past 10 years.
Thank you so much, Karli, for joining us today. It's a pleasure to have you here. So what drew you to obesity medicine? How did you kind of get your start in this?
So I did my undergraduate studies in psychology and physiology. I was very interested kind of in the mind-body connection as well, and really feel like you can't be healthy in one without the other. I went to graduate school to study clinical exercise physiology. I really didn't want to go into the medical route initially because I felt like we really need to be addressing a lot of the root causes that are causing so many of these chronic conditions. I was like, okay, I need to find some kind of a path that's more of a medical path that I can take. So kind of learned more about the PA profession. And I thought, this could be a really great fit for me. I initially went into medicine really to go into primary care and to really work on that preventative type of medicine. Well, I did work in primary care for a while, but I was finding that it was challenging. First of all, I was seeing a lot of like urgent care type things, a lot of, colds and sinus infections. And I was finding that even though we had a lifestyle and a health coach that I was referring patients to, I wasn't really seeing the changes that I was hoping to see. I felt like I couldn't really do what I'd hoped to do in primary care. And so I was a little bit lost. And I started going door to door at different medical practices. And I just kind of walked into a bariatric surgery office with my resume. And so that's kind of how I fell into, if you will, the field of obesity treatment.
The way that primary care is set up nowadays and the amount of patients that you have to get through, it does feel like a losing battle. I can understand why you had so many frustrations in primary care and why you found like more of your fit in a bariatric surgery office.
Part of it had to do with time, and that's certainly an issue and always will be an issue in primary care. But I think a lot of it was also that I didn't understand obesity as a disease. Advising somebody to eat less and move more is just simply not helpful, because when somebody has obesity, there's a dysregulation of that energy regulatory system in the brain. And if appetite is out of proportion to their caloric needs and people are hungry, that's a very strong physiologic signal. I mean, there are certainly certain specific nutrition plans that we can use that affect some of these appetite regulating hormones. That can be helpful for some people, but for a lot of other people, they do need additional support, like medications, just like we do for any other chronic disease. It's really no different than treating hypertension or diabetes. Yes, the lifestyle components are very important, but a lot of times we may need a medication to really help control that disease state.
Yeah, I think you have some great points there. What you said about training. I mean, we just don't learn. I don't think it's just PA school. I would venture to say in med school, there's probably not as much training and emphasis in talking about metabolic disorders there as well.
Yeah, that's very true. And obesity, I graduated in 2009, and the American Medical Association didn't classify obesity as a disease until 2013. So at that time, you couldn't even really diagnose it. That was not considered a medical condition. Now it is, but it's been almost 10 years now that obesity has been recognized as a disease. And yet still there's very limited training in and around obesity at any medical training level. So that's something that we're really trying to change, because it needs to happen and we need to start getting insurance coverage. This is a disease. This is a disease state. And how can we not be treating this? And as medical providers, we spend most of our time treating those complications of obesity without treating the root cause of the obesity itself. We need to be doing this. There's no reason not to be, and it's really inexcusable for us not to start treating obesity.
So what does a typical day look like for you, and what kind of setting are you working in?
As far as, what does a day-to-day look like? In the practices where I worked, where we didn't necessarily have dietitians or exercise physiologists working alongside me, I was doing all the nutrition counseling, the exercise counseling, managing the medications, labs, all of that. In that setting, usually my new patient appointments were an hour and follow-up appointments were about 30 minutes. I would typically see patients initially, we'd have their initial appointment, which was really a lot more just information gathering. And then I'd usually like to see them back in 2 to 4 weeks so that we can really get them started on their treatment. And then in other settings, so like in the telehealth company that I was working with, we had dietitians and exercise physiologists. So usually new patient appointments were 40 minutes and follow-ups were about 20 minutes. So it kind of depends on your setting and how much support you have. But in general, I would say, I would see typically between 10 to 15 patients a day. That's probably about typical for me.
Are there medications for obesity, weight loss that patients can be on long-term?
Medications like phentermine, phendimetrazine, diethylpropion, those have been around since the 1950s. And in the 1950s, we did not understand obesity as a chronic disease. We thought it was simply a matter of changing habits. However, since then, we have learned a lot more about obesity and about appetite regulation. And we now recognize that it is a chronic condition. And so any medications that have been developed since 2012, all those newer medications are all approved for long-term use, whether it's, phentermine topiramate, which the brand name's Qsymia, liraglutide, which is Saxenda, bupropion naltrexone, which is Contrave, the new kid on the block, Wegovy, which is semaglutide. All of those are all approved for long-term use. And even phentermine, while it is still not FDA approved for long-term use, many clinicians do use it long-term. You have to know your state laws around that. There are some restrictions in some states. And the Endocrine Society has put out a great paper about, chronic use of phentermine, and there are some studies that support it.
And so it seems like when you're talking, I'm getting at the tools in the arsenal that people have for obesity medicine. It seems like it's the medication side, surgical side, and then also then from the blend from the psychiatry side. Does that sound like the three main tools that you have in obesity medicine?
So the means model that I've created, the M stands for medical. So you're really looking at, underlying medical conditions that could be contributing to weight gain. Medications, there are so many medications where one of the side effects is weight gain. And then the E stands for, I call it emotional well-being. So that's kind of the psychological side. There's many other reasons why we eat other than hunger. We get this dopamine release, this serotonin release, especially when we're eating these highly palatable foods. It can be almost like an addiction for a lot of people. That's the side of it that we definitely need to address if there are emotional drivers. Also, of course, mental health conditions. So we know that there's a bidirectional relationship between obesity and depression and obesity and anxiety. So then the A stands for activity. So we know that physical activity is important just for overall health. Exercise or physical activity is not really going to lead to a whole lot of weight loss, but we do know it's important for our overall health and especially for long-term weight loss maintenance. Then the N stands for nutrition. So obviously nutrition plays a huge role in this. We know that eating sufficient protein is very important for appetite regulation. Eating whole foods, foods that have fiber in them is going to be important. Avoiding those highly processed foods, which actually are going to stimulate appetite more. And then the last part is sleep. So sleep is crucially important for our overall health, but also for our weight management. And there's so many people who either have underlying sleep apnea or so many people that just are chronically sleep deprived or have poor sleep quality. So I would say those are kind of the main things that we want to be looking at when it comes to obesity management. And each patient's going to be different.
It is definitely a complex topic and a complex medical condition. And it is too bad that we don't get as much education. But speaking of education, and when I see your logo behind you, Gaining Health, so you don't own your own clinic or anything right now, but you have your own company around obesity health. Is that correct?
Yeah, that's correct. So there are some great places for people to get the education. And I think that that's the first step is become educated. So there's several places where you can go. AAPA has an obesity toolkit, and they have the primary care certificate in obesity management. So for PAs, that's a great place to start. I would highly recommend the Obesity Medicine Association, and they have a certificate of advanced education for PAs and NPs in obesity management. And I have all of these places listed and all these resources listed on my website, gaininghealth.com. So I started Gaining Health to really help with that gap between the education and then applying it. So I wrote a book on developing an obesity management program, and it talks about, creating your business plan and how to do the billing and coding and all those, technical things that you have to understand how to do it. And then also online forms and templates that can all be adjusted to your own needs. I'm just trying to make it easier for people in hopes that more people will start offering obesity medicine to their patients, because there is just such a need.
Yeah, and I think that's a good point. So often I, do these videos to give people an idea of what specialty they want to move into. There is also the opportunity sometimes to make niche practices within the practice you're already in. Oftentimes in medicine, and I'm sure I'm not the only one, you feel like, why are we having to reinvent the wheel every time we want to do something? It's like, surely I'm not the only person that's ever had this struggle. I think it's becoming a more of a thing for people in medicine to have that kind of entrepreneurial spirit and to realize where the gaps are, and for us to step in and fill those gaps. So I love that you did that. So these products that you have, they're available on your website, right? And I'll put the link to that down below so people can go check it out. So you're saying there's a range in the products to cover people's needs.
Yeah, it really covers everything from just wanting to kind of start a program within an existing practice. And I kind of go over different scenarios because there are so many different situations. And that's the exciting part, especially I think for PAs and NPs, where, we're trained as generalists, but we work in all these different specialties. So we're really uniquely positioned to be able to do this and to have this niche within whatever specialty we're in. I really see us as the leaders in obesity medicine and as the ones who can really, fill this role and fill this need for our patients.
Yeah, that's cool. That's a very cool vision for PAs and NPs out there. Now, do you happen to know, they often have very specialized certifications. They don't have any kind of specialized obesity medicine certification that you're aware of?
No. So for physicians, there's the American Board of Obesity Medicine that physicians can get board certified in. At the moment, we are not able to take this exam, and there is no board certification for us, which is why we have things like the Certificate of Advanced Education through the Obesity Medicine Association. So that's kind of our goal, is to eventually have some type of a board certification available. So that's something that we're still working on.
Okay, that's interesting. So people should watch for that. And I would love to see something specific for PAs and NPs to help us stand out and become experts in that field. You talked about bariatric clinics and centers. Are there just the medicine side clinics that are just solely devoted to the medicines? And does it still tend to be either a surgery clinic or a medicine clinic, or are they starting to meld more together?
So right now there are separate clinics. So there are bariatric surgery clinics that just do surgery. But more and more, we're starting to see that they're adding the obesity medicine side to it, because there's just this growing recognition that even when patients have had surgery, that many of them do end up experiencing weight regain. So more and more, we're starting to see these comprehensive centers, which is I think the direction that we need to go in. There are also plenty of practices now that are medical obesity treatment clinics who will refer to bariatric surgery, or perhaps have a relationship with a bariatric surgeon in the area, so that they can refer those patients who really need bariatric surgery to those centers.
So if you are somebody who wants to mainly work in surgery, you're more interested in the surgery part, are there opportunities to pretty much be like almost a full-time first assist, or do you know people that do that?
Yeah, absolutely. So it really depends on what you want to do. There are providers who they just want to first assist. They really just want to work in the OR. And so there are people who do that. There are also providers who say, I don't want to first assist at all. I really just want to do the pre-op and the post-op counseling and the workup and the medical management. It really just depends on what you want to do. I would also encourage people, don't wait around for the perfect job to come around. Just create it yourself.
That's such a great message. There's a lot of contention everywhere in medicine, but there's also so much opportunity. Okay, so when we're talking about obesity medicine, I always ask about the patient population. Does it just pretty much follow the BMI guidelines of what puts people into obesity? Or are you working with people who are also concerned that they're heading that way?
Yeah, I think, I don't have a hard rule about a BMI number that I will or will not, accept or talk to. Somebody might be within either a normal BMI range or maybe in the pre-obesity or overweight range, but they've had a 30-pound weight gain during COVID or whatever the situation might be, and they're concerned that they're heading in that direction. The discussion is always around health. Has nothing to do with cosmetics or any of that, right? This has to do with your health. It's so important that we get that out there. But, if somebody is starting to develop complications of their weight, like they're starting to develop prediabetes or hypertension, or they're developing complications, I don't care what their BMI is. We need to work with that patient. In general, I do tend to see people obviously of higher BMIs. And I will also say BMI is not the only thing we look at, right? We have additional tools like body composition analysis available. So we need to look at things beyond BMI. For those who don't have body composition available in their office, a waist circumference is also a great place to start. If the BMI is over 35, and it's clearly not like because they are an Olympic weightlifter, right? Then you need to start looking at these things. If the BMI is under 35, do a waist circumference in addition to see if there might be something else going on that you need to start addressing.
Oh, so what about pediatrics? I mean, obviously childhood obesity is just becoming rampant. Do most bariatric clinics deal with pediatrics, or are there specific pediatric providers for that?
So it depends. So if we're talking about bariatric surgery, that does need to be a very specific center that has those qualifications. So for pediatric bariatric surgery, that's very specific. Usually those pediatric bariatric centers also have medical treatment, but there are some clinics also that just do obesity medicine within pediatrics. Some pediatricians do it as well. It's really important, obviously, that you get trained in this. And the Obesity Medicine Association has great education for pediatric obesity management. They also have the pediatric obesity algorithm. So for those working with that population, there's a lot of good education and resources. And we now actually have some medications that are also approved in the pediatric population. I personally have only worked with adults, the adult population, but I know that it's a growing field and there's a huge need for this. So for those people working in pediatrics or who have an interest, I would highly encourage them to get educated around that and to start working on that as well.
So what are the things that you absolutely love about obesity medicine and that you think make this a great specialty for people to consider?
Well, I think the thing I love about it is you really get to just change somebody's life. And it's such a hopeful field of medicine. It's happy medicine, as we say. It's amazing to just see this transformation. So that's, I think, what makes it an amazing field to work in. Yes, we do see a lot of success. And of course, not everybody's going to respond to every treatment. And some patients are going to have situations that are just very challenging to overcome. And I think the key to this is motivational interviewing. When I first started in obesity medicine, I thought that I had to have all the answers and I had to have the perfect nutrition plan and the perfect plan and to tell the patient what to do to be most successful. And if you take that approach, you will be frustrated all day long. And so just throw all of that out the window. You literally just have to come in with an open mind, meet the patient where they are and ask them, what is something that you're struggling with right now that, we could work on together? Is there one thing in your nutrition that you would like to change? So most of the time, the patients have all of the answers. So you're really there to just support them in all of that and ask them, what would you like to change? And how can I help you make that change? So I think your approach and using motivational interviewing and really meeting the patient where they are is key to it.
So people that are coming to an obesity medicine clinic, they're actually coming because they're motivated, right? Is that the patients that you're getting, or a lot of them just being referred and sent there kind of not against their will, but not something that's their idea?
Yeah, I think we see both. I mean, I think certainly as an obesity medicine specialist in obesity medicine clinic, there's going to be, a bias with the patients that I see. I probably am going to see more patients who are ready to start making changes versus if you're bringing up the topic in primary care or something like that. But we do have a lot of patients who get referred to us. Perhaps they need to have, a knee replacement, but they need to get below a certain BMI before their surgeon can do the operation. So they get referred to us. So it's not always the patients that are, really motivated and choosing to come to see us. Ultimately, if they're not ready to talk about this, we have to respect their autonomy. And you just have to be able to say, okay, I understand, and weight is a complex issue. And I've had some training around this. So if ever at any point in the future you wanted to come to me and talk to me about this, I just want you to know that I'm here for you to support you with this.
So we talked earlier about lots of resources to help people to get more information and be better providers when it comes to talking about obesity and weight. Are there any other resource or anything else that you would point people to?
Yeah, so I am very excited. We just launched our PAs in obesitymedicine.com or .org, doesn't matter, website. And so this is specifically for PAs. It's a membership. It's only $50 annually. And this is really important because this is what we need in order to become a caucus. And we also have a job board there. We're going to have lots of resources. We're going to have CME and all kinds of other events there. So for PAs who are interested, I would really join PAs in obesitymedicine.org.
And kind of the last question I always ask is this a specialty that you think is new grad friendly? Is it something that you think people can graduate and kind of just start in? Or do you really think they need to get a good foundation in family medicine or somewhere else first?
I think it could be new grad friendly. Anybody who wants to go into this field is going to need additional training because regardless, in most programs, they have not received sufficient obesity medicine education. But for new grads, I think it could be a good field. You do have to be aware that you need to understand the family medicine side a little bit as far as, medications, which medications cause weight gain and how you might be able to adjust those medications. But if that is something that you're not particularly comfortable with, work with the primary care provider or whoever's prescribing those medications. I do think it is a field that is open to new grads. I think anybody who takes the initiative to learn more about obesity medicine and who is really interested in this type of a long-term relationship with patients where if you're a good communicator and you have some background in motivational interviewing and those types of things, I think it would be a great fit for anybody like that.
And one thing I didn't ask about is I always try to give people an idea if they're looking at the specialty of obesity medicine, what would the salary be like? Is it kind of going to be on par with family medicine, or does it tend to be a little less, or does it tend to be higher?
Yeah, that's a great question. And Debbie Horn actually presented on this a couple of years ago, and it's mostly on par with primary care, especially if you're working in just obesity medicine. If you're working in bariatric surgery, again, that's a surgical specialty, so it might be a little bit higher. But in general, it's going to be on par with family medicine. And also that's because obesity medicine is not recognized as a specialty yet. So there are no, specialty co-pays or anything like that patients pay. So it's really more on par with family medicine.
When you talk about being like a first assist in bariatric surgery, obviously the larger people are, the more difficult surgery is. Are there specific challenges that you felt first assisting in bariatric surgery?
Well, I don't have a lot to compare it to because I didn't do a lot of first assisting in any cases other than bariatric surgery. But I will say, a lot of times patients with higher BMIs do need to have significant weight loss sometimes before they can have the bariatric surgery procedure. So that's another place where I think understanding and having a good knowledge of medical obesity treatment is really important. Of course, there are additional challenges with anesthesia with these patients. We have specific bariatric protocols for all of this. Bariatric surgery wasn't particularly demanding in any way, but it's all done laparoscopically. So really, once you're in there, it's just like any other laparoscopic procedure, I think.
And this is another kind of strange question that just popped into my head. But if people are thinking about wanting to work in obesity medicine, but they themselves have a higher BMI, Do patients respond to that, or do patients expect their obesity medicine providers to be thin and a smaller BMI?
That makes you even more relatable to your patient. If you can share part of your journey, that what you're doing and how far you've come and what's worked for you and what hasn't worked for you. So I think you definitely, even if you struggle with this yourself, that's a great way to be able to connect with your patient on some of these issues. So I think regardless of what size you are, you can be a great obesity medicine specialist. And even if you haven't struggled with your weight, that doesn't mean that you can't be a good obesity medicine provider, because just like anything else, right? You don't have to have had cancer to be a good oncologist, as long as you understand the science. You understand that there are numerous causes, and that you understand the biology behind it. You understand the pathophysiology, and you know what the treatments are to be able to help them with this. I think regardless of your own size and your own journey, if you have a weight journey yourself, you can share that and connect with your patients on that level. And if you haven't, that's okay too, as long as you understand the science behind it.
Great answer. And how about just last parting thoughts? Just if you are, talking to somebody, what would you want to say to them to kind of give them that final push towards either working in obesity medicine specifically or starting kind of a niche practice within their current practice?
I would just remind everybody that there are over 236 medical conditions that are either caused by or exacerbated by obesity. And I think we all went into, or at least most of us went into the medical field because we want to help people. We want to help people be healthier. And this is what we do in obesity medicine. You're getting at the root cause. You're getting to integrate some of these lifestyle factors with medicine, with real evidence-based tools. And it's just so important. By 2030, over 50% of the population will have obesity. And we just can't continue to ignore obesity. This trend can't continue. And so if you really want to have an impact on your patient's health and really help them get healthier from the inside out, obesity medicine is just such a great way to do that. And I know a lot of providers are frustrated too, and patients are frustrated with the way that things are going. So I think really this is a way to revolutionize the way that we approach healthcare and chronic medical conditions.
Good stuff, Karli. Thank you so much for joining us today, and thanks for sharing your words of wisdom with us.
Well, thank you so much for having me.
If you would have asked me before this interview, I would have thought that obesity medicine is probably a very frustrating specialty to work in. And I would have the mindset that you would be all day contentious with patients and trying to get them to do the right things. But now after talking to Karli, I realized that it's a whole different mindset. You're kind of a team member with the patient and figuring out the puzzle of the different tools that we can use. It's not just you having to try to convince a patient to do something. So she's really changed my thinking on that. So it's kind of curious to me, making me think that maybe I would really enjoy obesity medicine. So how about you? Is this something that you would ever think about? Let me know your thoughts down below in the comment section. I'm pretty interested to hear what people have to say. So if you want to learn about other specialties, or if you want to learn about how you transition into specialties, you can watch these videos here. You also can go to my main channel page and look at the different playlists that I have for PAs and NPs. Thanks for joining me again today. Take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.